Welcome and thank you for standing by. At this time, all participants will be on a listen-only mode until the question and answer session of today's conference. At that time, to ask a question, press star followed by the number 1 and record your name at the prompt. This call is recorded. If you have objections, you may disconnect at this time. May I introduce your speaker, Vidhu Shekhar. Please go ahead.
Good morning, everyone. Hope everyone had a great Labor Day weekend. Thank you for joining us for the second webinar in our series of webinars for the Washington ACHs that we're working with. Our agenda for today is really to go over, the experience that Staten Island PPS had in its establishment and their experience during the demonstration years. Towards the latter third of the webinar, the last 30 minutes, we will open the floor for questions and answers. And at that point, I'll have the operator go through the steps required to be able to ask the questions as well. At this point, I'll request Evelyn, the Managing Director from KPMG on this project, to take a couple of minutes to introduce our formal speaker, Joe Conte.
Hi, good morning. Thank you, Vidhu. So we're very pleased that we were able to snag some of Joe's time this morning, given that the New York State performing provider systems are still right in the midst and the throes of their DSRIP program. They're on year 3 right now, headed into year 4 in a couple of months. And so there's been a lot happening and there's a lot still to happen. And Joe Conte currently serves as the Executive Director of the Staten Island Performing Provider System, which is born out of where Joe was previously working, Richmond University Medical Center, as well as the Staten Island University Hospital Center. And together, those two hospitals with all of the surrounding providers on the island form the Performing Provider System, one of 25 in the state of New York. Staten Island has been recognized multiple times over for several performances, mostly for leading the way and being one of the most advanced PPSs in the state. And so we're very happy that Joe has been able to carve time out of his schedule to talk to us today about the experiences that the Staten Island PPS has gone through, specifically with a nod to the financial management of the PPS, as well as some of the HIE-HIT developments. And we really want this to be interactive, and so if there is a way that you can ask a question beforehand, we'll confer with the operator. I think if you press *1 or *0 in between, we might be able to get your questions in sooner than at the end. We have a pretty jam-packed agenda. Joe's going to walk through a couple of slides outlining what the PPS looks like, how it works, and then especially hone in on the experience from the initial years on the setup and what was learned from that, hopefully for the benefit of you all at the ACHs in the state of Washington. And so without further ado, Joe, it's all yours.
Good morning. Thank you very much for the introduction, and good morning to everyone on the line. I appreciate you taking the time to listen to what we're doing here at Staten Island PPS. Evelyn and I started working together about 3.5 years ago. The time goes very fast, and that was during the pre-formation of the PPSs during the planning process, which I understand most of you are still in the midst of in organizing your program. So I'm going to, as Evelyn said, take you through our PPS, where we're at, what we're doing, how we got to where we're at, and some of the challenges, some of the lessons learned, and some of the takeaways that I hope will be beneficial to you all. Staten Island is a community of about 500,000 people. About 180,000 are impacted by the Medicaid redesign project, so it's about 4 in 10 Staten Islanders. And we were very fortunate at the outset that the community organizations, in addition, of course, to the hospitals, were very much in favor of a unified performing provider system in our community and not trying to split up by traditional marketplace boundaries. So every one of the 10 nursing homes, the behavioral health providers, the federally qualified health centers and the like were really engaged during the planning process, where the folks from KPMG really helped us a great deal as we prepared a community needs analysis and started working with partners pre-DSRIP to identify the appropriate projects that we wanted to put the resources towards, to identify the manner in which the partners would engage in the work together, and to identify how we would be able to work through funds flow, data information sharing, and a governance model that allows providers, whether they're the largest or the smallest, to feel that their voice is heard, their contributions are valued, and that from a financial standpoint, the benefits that they receive are commensurate with their participation. We could proceed. Next slide. And I think jumping right into the middle of this is important to recognize, and you all will be experiencing the same thing, that we're in moving from a fee-for-service world to a value-based purchasing world, moving away from process to outcome is something that, while many organizations have some modest experience with, when you look at a slide like this that lets you see that by year 4, 2/3 of your payments and then greater than 80% are going to be based upon value and outcome and specific indicator monitoring and performance along those lines in a consortium of partners that in some respects still remain competitive with one another, is something that is pretty heady stuff. It's a true transformation that's required to get where you're going, and as we are now in DSRIP Year 3, as Evelyn mentioned, we're better than, just slightly better than 50% are still related to process measurement payments. There is really a redesign at every level going on in ways that sometimes we anticipated at the beginning, sometimes we did not, and we're going to jump right into some of that learning as we proceed right now. And the next slide, I think, gives, it's a packed slide, but it really tries to capture the breadth that is required to transform the healthcare system that works with so many different kinds of partners, so many different types of patients and clients, and understanding that this bridge from fee-for-service to transformation in value-based and outcomes really requires a true redesign of the fundamental aspects of everything that we do. So moving towards person-centered care that is truly integrative in every way, that is supported by a combining of behavioral health, medical, and community-based organizations that provide social service housing, focusing on social determinants of health aspects, is absolutely essential to success. Tinkering around on the edges and doing some modifications to accommodate smaller partners does not work in this kind of a transformation project. Everyone needs to be at the table and, in a way, be involved in the transformation, because in many respects you're looking at not just a clinical transformation, but also the transformation when it comes to focusing on cultural competency and health literacy, workforce redesign, addressing stigma in the community, medical education. These are truly the bedrock of everything that we do, and it is incredibly important to recognize that the ability to make that change is the kind of transformational component that is going to be the only way for success in the future. So the next slide talks about the funds flow, because ultimately we do know that regardless of the level of cooperation and the willingness and goodwill that partners bring to a program, there are risks, and those risks certainly manifest themselves in many ways, but financially certainly is a very profound one, because it's the difference between an organization transforming and becoming part of a new order and those that will not make it, because we do know some organizations perhaps may not adapt. So the funds flow is extremely important, and I think without getting too far into the weeds here, I do want to talk about some very important principles. And those principles are the ability to minimize overhead expense is an absolute priority, and I think we spent a great deal of time during our planning process in ensuring every dollar that we spent was needed or was necessary, was going to have an important deliverable for the partners, and that the maximum amount of funds were moved towards the cost of implementation of projects, incentive payments, and a category that we called revenue loss and innovation funds. And these things, again, I think have served us very well because, you know, ultimately partners do experience revenue loss, whether it's in emergency room services, admission and readmission to the hospital, better focus on ambulatory sensitive care that reduces the need for high cost and high revenue generating in some respect. And these are things that many providers have relied on in the fee-for-service world, and as we move into value-based and outcome measurement for population health metrics, some of this will be lost as we proceed. And innovation really is at the core of Medicaid redesign, and we set aside dollars for innovation from the projects because we wanted partners to come forward with strategies that were would reward outside of the box thinking, even if they did not have legs for the long run. We felt that disruptive approaches were important to reward and to try to incentivize, and we could talk a little bit about some of those as we go along. I just want to let everybody know our Director for Project Management, Ashley Blauvelt, has just joined me, because as soon as I say something wrong, she'll be tapping me on the shoulder and saying, that's not what we're doing now. So, Ashley, thank you for joining me.
Good morning.
In the next slide, you'll see the funds flow principles. And these principles were extremely important because, you know, there is, if you will, a size gradient and a power gradient when you work with many different sized organizations. Organizations that are community-based organizations that have great impact and social determinant factors generally are not large revenue generators. They don't have the kind of voice in many respects that hospitals and large mega medical centers do. Community-based practices of 1 to 3 physicians don't have the same kind of voice or depth of scope that federally qualified health centers may. But each and every one of them is extremely important. And the fund flow principles that we hashed out very early on with the input of many of these providers was that we needed to look at a way to create equivalent payment per unit of work, irrespective of the size of the contribution or breadth that the organization had. And this, of course, is something that was complex and required a lot of time, and in many respects, even now, kind of sometimes tests our ability to implement it with fidelity to the principles that we had, but we really do feel in every way and every project that we work on that that is one of, if you will, the golden rules that has kept everyone at the table that we're working with. And we're very proud of the fact that during the first go-round of independent survey of the partners throughout Medicaid redesign, our PPS was identified as the top performing when it came to provider satisfaction. 97% of the providers surveyed demonstrated that they had very high satisfaction with working with this project and this program and this administrative team a large portion of which is not just because we're nice and we put out a good work product and we support them in many ways that we'll talk about in the future, but because financially, from a fiduciary standpoint, they do feel that they are supported in the ways that they need to evolve. Project implementation support funds were supported based upon application from the partners, so organizations that needed project implementation dollars, that wanted to grow capacity, grow breadth. We set aside in every project that we selected a certain percentage of dollars, and it varied by project, that was set aside so we could support those programs. We supported small practices in moving towards a patient-centered medical home, and really made a real effort through our chief medical officer and others to reach out to small practices, because they do, in many respects, provide the bedrock for engaging a community. They have a lot of trust with the patients that they're trying to reach, especially if you're dealing with subpopulations that may be unique to the community, but really do impact utilization and services. So, for instance, in Staten Island, one of the unique things that we have is the largest Liberian population outside of Liberia is in Staten Island. So this is, a population that we have to work with in particular ways to make sure we engage them, that we build trust, and we get them into person-centered care. And, there was a list here of a number of these things. Some I spoke to earlier about the innovation funds. If you go to the third bullet from the bottom, I think this is an important foundation that we worked on, and that is that there is a risk-based model in place. If there's a network-wide miss, everybody kind of shares in the loss. So every partner is incentivized to not just do 80% or 90% or 100%, but to even go beyond and carry the water for their neighbor who may be in a trajectory of building when it comes to meeting project goals, because, the performance is aggregated across the PPS partners, and we develop some ways of rewarding those who overachieve and at the same time keeping those who may underachieve for a number of different reasons. Not everybody is at the same stage of development or program implementation, but allowing them to kind of, if you will, catch up. Because we have seen many providers early on have difficulty getting out of the gate, but with good work and support from the project management office and their peer providers, really, kind of in some instances actually even take the lead in certain projects. So this is really extremely important. And the focus on community-based organizations is one that we got onto very early, because we recognized that the foundation of engaging patients and the community is based upon trust, and community-based organizations are often the true experts in this, and many times it is not the large hospitals or not the large practices that are more institutional in their outward-facing components, but organizations that are truly built at the foundation level in the community by community members that are perhaps smaller in breadth, but very important in terms of developing the trust factors. I could stop there for a moment, because we're going to transition a little bit into some of the important components of how did we bring project implementation expertise to bear to support our partners. How did metrics and monitoring, which is Ashley's expertise, come to bear, and overall lessons learned as part of this. So if you want, operator, I'm happy to take any questions that may come up at this point.
Thank you. We will now begin the question and answer session of today's conference. To ask a question, press star followed by the number 1, unmute your phone and record your name clearly when prompted. Your name will be required to introduce your question. To cancel your question, press star followed by the number 2. One moment for incoming questions.
And operator, we'll be doing this a couple times during the call, so this is not the only Q&A session.
Once again, participants, to ask a question, press star followed by the number 1 and record your name.
All right, I mean, if nothing comes up right now, I hope I'm not putting anybody to sleep. I know it's early out there, but we will move along.
Perhaps before we go on, I do have a question on behalf of the group. It's about the revenue loss, since that's something we've discussed also in with the ACHs in Washington, where we've said, you know, try and minimize this, since what you don't want to have is that it risks becoming a dependency stream for organizations participating in DSRIP. We might get into this later, but how have you worked around the fact that you're trying to use DSRIP as the sort of stimulation fund, not creating dependencies for the longer run on a money source that will no longer be there in a couple of years?
So it's a really important question, both you know, in principle and in terms of motivation of the partners. And it really gets back to, in a way, some of the very high-level indicators to meet the CMS standard terms of in conditions are truly indicators that strike at high revenue. Right, so it's the use of the emergency room, admissions to the hospital, preventable utilization of services, and it really does have quite a financial impact on partners, especially hospital partners that derive a great deal of revenue from the source, and you know, to engender their participation, to kind of soften the blow of participating in a wholehearted way so that they really would bring resources to the table to work on mitigating excessive utilization of these services, which requires expanding capacity in other areas, reallocating workforce to locations that generate far less revenue. We thought it was important from a buy-in standpoint to make sure that revenue loss, while modest in scope, was given consideration so that from a financial standpoint, I cannot speak to the experience in Washington, but in New York State in general, the average hospital makes about 1% of margin. That means some hospitals lose, and of the 212 or so hospitals in New York State, 50 to 60 generally have a fairly heady revenue loss every year, and there are those, of course, that do quite well, and there's a large body, as you would expect, in the middle, making somewhere between 1/4% to 1.5%. So, you know, to get hospitals in particular involved in a meaningful way, we felt that it was very important to have revenue loss built in, not because it was meant to be a bottom line support, but that in some respects it was meant to be a financial asset for the hospitals to utilize in program redesign.
All right, thank you. I'll let you go on, and we'll build in some more Q&A sessions along the way. I know people are taking notes since they're texting me about it.
And Joe, I got a chat message from Wes that they're all awake, so we're doing good.
Good.
Excuse me, speaker.
Because once I get started, you know, it just keeps going. Okay, so let's move to the analytic slide, which is...
Joe, we might actually have another question. I heard the operator punch in there for a second.
Yes, we do have questions on queue. The first one comes from Jack Davis. Jack, your line is now open.
Thank you. Can you hear me?
Yes.
Great, thank you. I wonder if you could talk a little bit, and you may be planning to cover this later, but a little bit about sort of the legal framework for the PPS and the relationship between the different partner organizations. So, for example, did one entity step forward to serve as the administrator and fiscal agent and then set up subcontracts with the others, or did you in fact establish a new entity that would serve in that role?
Sure. This is a quick answer. We established a new LLC, and the governance is managed through the two hospital partners, with the operational aspects of governance being managed through a steering committee that is made up of about 16 partner organizations, the hospitals being part of that, but all of them having one vote. So at a board level, the hospitals are the predominant influence, but from a steering committee standpoint where operational and fundamental decisions are made about program implementation, it really is the partner group at large that has the majority voice. So there is no fiduciary from a financial standpoint per se. The new LLC is its own entity.
All right, thank you.
Sure.
Our next question comes from Dawn Bonder. Dawn, your line's now open.
Thank you. Good morning.
Morning.
I have two questions. So first, does the PPS in New York hold the risk, or is there also an insurer or Medicaid managed care organization involved in the work?
So right now in New York, the PPSs are not risk-bearing entities. The funds
And
that have been...
what is the relationship between the PPSs and the risk-bearing entities? I'm assuming they're Medicaid managed care organizations. If not, can you explain who they
Sure.
are and how the relationship works?
So the plans, in some respect, were not as actively brought into New York DSRIP as they might have been. I think that was one of the takeaways we'll talk about a little bit later, and there are some slides that we look at that. So the funds that we distribute are based upon all incentives, and the providers are still working with the plans independently. And what we hope to see as we move into DSRIP year 4 and 5 is that some of the PPSs will morph into new provider organizations that can either function in MSO-type capacity or will themselves be risk-bearing entities with plan partnership.
Okay, and then I just want to make a clarification around your earlier comments with respect to lost revenue. I am assuming that that is because the Medicaid rates paid in New York still provide a attractive payment to specifically the hospitals. And do you think it would have been different if your hospitals were losing money on every Medicaid patient that they served?
Well, I guess that, as they say, beauty is in the eye of the beholder. But so attractive, you know, Medicaid is much more of an attractive payer now than ever before. And I do agree that if, well, certain organizations, because of their inherent cost structure, Medicaid is not an attractive payer. Primarily, it is right now, and it is something that is being pursued by many organizations throughout New York State.
Thank you.
You're welcome.
There are no more questions on queue at this time, speakers.
All right, so in the next slide, I think one of the things that we'll talk about now is the capacity that the PPS built to support analytics and data management was one that we recognized from working with our partners very early on was one that even the hospitals, in many respects, lacked the capability to oversee this kind of 360 view of a patient that is required to truly look at utilization over time between partners, manage information, and do it in a way that would create this transformation towards a more successful value-based focus with population health metrics and the HEDIS indicators, which are the primary indicators that we are measured by as indicators that we're likely to be successful. So across those 6 panels, you'll see some simple examples of things that we have created to support the work. And as we proceed through the next slides, we'll get into that in a little bit more detail. But I will say from a standpoint of a must-have, any organization that is going to engage in value-based purchasing and Medicaid redesign under this program in Washington State needs to develop a sophisticated capacity to bring business intelligence to the partners in a way that I suspect has never been done before. In our case, what we did was set up an electronic data warehouse, and as we move into the next slide, we call it a value-based care data management model, which we built upon not only receiving claims data, which, as everyone knows, is often 6, 9, or 12 months delayed, but also to bring in data from our hospital partners every night at midnight into a data feed, to bring data in from our health home at risk and health home partner every night at midnight, to bring data in from federally qualified health centers and primary care practices on a monthly basis, to receive long-term care information on a monthly basis as well, to try to create a kind of a mosaic of information flow that really allows us in real time to look at how partners are performing against the measurement rubric, so that they are not surprised later, and the PPS is not surprised when the state is issuing its distribution funds. So it is a complicated measurement model. Ashley is going to talk some more about that as we proceed. But we know that without having good interoperability and the ability to bring information in and use it against a measurement portal that the partners can see for themselves and push information out and share it, it becomes very difficult to achieve success in this type of program. I think one thing that we have and continue to work on is how do you bring in social determinant of health variables here, because looking at traditional utilization patterns on a clinical standpoint certainly is informative, but looking at rising risk, looking at how housing, employment, the safety in a neighborhood, the quality of the schools, and such other variables is extremely important, and it really allowed us in many respects to help identify partner organizations to continue to bring into the fold and work with the PPS, helped us identify certain programs that were not necessarily part of our project menu, but programs that we believed were extremely important to work on, like asthma and obesity, such that they impact in the long run the likelihood of success in the program. And the other part of this, I think, and you'll see in the next slide, is the ability to turn this data into business intelligence. So as you see in the next slide, rapid cycle performance feedback to partners is extremely important. If we'll move to slide 8, you'll see that it is extremely important. Could we advance the slide, please? In slide 8, what you'll see, if we have caught up, is that rapid cycle feedback to partners and their ability to ultimately manage information on indicators is extremely important. And we set up a fairly rigorous and disciplined data management model very early on so that partners got used to managing data on the individuals that were part of the individual projects that they were working on. We have 11 specific projects that we're involved in. Not every partner is working in all 11. In fact, no partner is working in all 11, but some may be involved in as many as 7 or 8. And the ability to look at indicators, to measure where resources have to be applied at a partner level is extremely important. I think all of the ACHs will experience this as you all advance in your program development. The PPS really doesn't have operational authority over any individual organization. What we do have is, of course, the carrot and the stick of finances, the goodwill and a meaningful effort that everyone wants to put forth to improve the population of our partners. But in many respects, most partners never had a data management capacity to look and delve into this kind of longitudinal trajectory of a patient's care over time. So data collection, defining measures, analyzing, performance reporting, and measuring change after a program is implemented is extremely important. And it probably is one of the strongest suits of our PPS in New York State, and it is one of the things that has led our Medicaid director here to call us, as the most advanced and leading the way when it comes to program implementation, because you cannot effectively implement program without understanding how your performance is moving along with the program redesign that you're working on. And I think it's important, that word is important, redesign. No organization has been successful in any of the PPSs in New York State that has not looked at redesign and transformation as a fundamental aspect of what they're doing. Trying to tinker on the edges with how projects have been implemented in the past and how clinical programs are exported into the community and all of that is not a recipe for success. And it really, in some respects, can be somewhat daunting to organizations. So picking partners well and understanding their capacity and their need for support, I think is something that the ACHs really need to spend a great deal of time working on, because you want everyone to be as successful as they possibly can be, and that means providing support at different levels. So the next slide will show that one of the things that we have spent a great deal of time working on is being able to drill down and using data visualization tools to really pinpoint and geocode and hotspot where excessive demand for services is cohorted in our community, and being able to drill down on those individual dots allows us to look at individuals that demand a high level of utilization because of the conditions that they have. And we have assembled a very sophisticated and high-performing data analytics team here that is probably the envy of every PPS in New York. And it allows us, and if you'll advance through the next couple of slides, it'll outline some of the key statistics, there you go, that we look at when we drill into some of the population. And it allows us to look at disease-specific, race-specific, age groups, particular years, gender, and conditions and comorbidities, and look at performance over time in these cohorts. And this really has been a very powerful tool for us, and it has allowed us to drill down in particular conditions so that we can, again, inform partners of not only their performance in individual ways in the cohorts that they're managing, but even within the geographic zip codes and regions that they're managing, and looking to see where resources can be combined, where partners can work together to bring culturally competent, health literate care along with care outside of the traditional bounds of the bricks and mortar of a hospital or an FQHC, but perhaps even using mobile health and outreach into public housing and different locations where we see hotspots of demand for services. So if you'll move on to the next slide, what you will see is perhaps a little bit more of a description that I raced through a couple of moments ago about how we bring in longitudinal records, how we use risk stratification to identify cohorts of patients that have excessive utilization of services, and try to work with our partners to identify outreach efforts. You know, obviously we can't include every slide in a conversation like this, but we look, if you had gone back to that population health side, but we also do this looking at our EMS utilization for ambulance calls in particular locations. So who are the top utilizers of ambulance calls? What is the reason that they're calling for services? Why, when do they call? What's the shift? What's the day of the week? What are their primary conditions? What are their comorbid conditions? You could advance again, back to the next slide. So this really does allow us to bring in, you know, a very focused way of looking at the work and sharing data amongst partners. And of course, you know, we could have a whole hour-long or even longer conversation about how do we achieve data sharing, how is consent utilized amongst partners, what has the Department of Health done here in New York to get patients to opt in for data sharing and things like that. And you know, again, I think a conversation for another day, but without sophisticated business intelligence grounded in encounter information as well as claims data, it is nearly impossible to be successful in this kind of transformation. So in the next slide, we get into focus on gaps in care and measurable outcomes. And I'm going to ask Ashley to talk about this and spend you know, a good 5 minutes or so, because I think we're doing okay on time, so that she can share the information that we move out to our partners in multiple different ways, either through a portal or through secure emails, so that they can manage their populations and look at where they need to apply resources. Ashley?
Thanks, Joe. So we get our performance updated from the Medicaid Analytics Performance Portal, which gives us our measure results for the selected measures that we have for DSRIP. We look at those measures across partners, and we use some of the other data that we get from the partners to match the patients on their rosters, and we match claims data that we get from the file, which is given to us by the Department of Health. So the measures are based on DOH claims data that come in, and we also use the hospital utilization reports from the feeds that we get from the hospitals to match different real-time performance. There is a lag in the claims measures that we do get from DOH, but we do try to use all of the resources that we have through our own data feeds to get a better proxy for how we're doing. So when we do get the results, we look at our performance by partner, and we look at the rosters, and we determine with some type of loyalty attribution where these patients belong, and then share downstream reports that let partners know which patients are failing which measures. We give them a report that gives them the patient SIN number, which is their Medicaid ID number, their name, gender, date of birth, We're also working with managed care plans on sharing some of these reports as well for better care coordination. We look at health home enrollment. We do have one of our partners that helps us make referrals to health homes, so we see if there's any way that we can leverage those resources. And then the managed care assigned PCP, which helps us with some of that loyalty attribution. So then we look at behavioral health measures and then some of the medical measures. And so we do have some of those HEDIS measures for behavioral health, which are the follow-up after hospitalizations for mental illness within 7 and 30 days. We look at cardiovascular monitoring and diabetes monitoring for people with schizophrenia, other antidepressant medication adherence. And then we look at, on the medical side, the diabetes care for A1Cs and LDL tests, retinal eye exams, all of the other comprehensive diabetes tests, looking at potentially avoidable readmissions, and then potentially preventable ED visits for both behavioral health and emergency and all of the other domains, if you will. And so we ask our partners to report back to us in real time action plans on whether these patients have met the measures in their records so that we can reconcile with DOH and compare back to the claims data to get more of that proxy results, as well as ensure that our partners are doing everything in their power with the resources that they give them to ensure that they, at a patient level, are able to engage and help move the dial on some of these measures.
Very good. Thank you. And I think something that is important that Ashley touched on is that we see, especially in the Medicaid population, even the uninsured to a large extent, that they don't just get care in one location. So communication between partners about outstanding gaps in care is important, and managing it in a way that confidentiality is assured is certainly likewise important. And we have done, I believe, a very good job, and as what Ashley talked about, looking at loyalty factors so that we can create profiles, share data with the minimum amount of spread, which is required by the New York State Department of Health Data Security Bureau, and at the same time maximize the capability of individuals to close specific gaps in care that may be unique to their particular provision of service. So as Ashley talked about again, whether it's cardiovascular monitoring or diabetic monitoring in a person who's on anti-schizophrenics or antipsychotics, that can best often be achieved in a behavioral setting because those individuals are getting regular service there and may not get back to the medical folks that are doing, we hope, their well visits throughout the year. So, you know, trying to bring groups together to create integrative care, to support NPs and PAs going into behavioral settings, you know, this kind of redesign is extremely important because when you're dealing with the kind of measures that we're talking about, the ability to work at a unified purpose for gaps in care and get that information, again, in this idea of a business intelligence type model into providers' hands is extremely important. And, you know, we are working with several of the EMR vendors now to develop self-populating gaps in care directly into an EMR so that there is less need for providers to be reliant on the traditional huddle in the morning or work lists and things like that, such that when they get into an EMR, patient shows up for a particular service, they can also close specific gaps in care. But I don't want to get too far down in the weeds, but those are extremely important things to think about as you all are going down this redesign model that you're thinking about. So in the next slide, we had a question earlier about managed care organizations and how managed care organizations are involved. I think we're finally seeing that the plans are getting much more engaged. Some of that is because of financial incentive and disincentives that the Department of Health has implemented, and others because they recognize that we really are aligned in many respects. The plans are measured by the same HEDIS measures. Their quality scores that are used to pay a portion of their payments to them are the same, very same measures that the PPSs and the PPS partners are striving to achieve for the benefit of the patient. So we have taken to looking at not only how a particular provider does when it comes to providing service in that gaps in care report, but we actually turn this on its head and look at how individual plans do. And then we go back to the plans, and because we have achieved what the Department of Health calls a production environment for our data management, which was, we were the first in the New York State to achieve that, we can now share roster data with the plans, and we can share with them where these gaps in care are. They can reconcile it with the information that they have, which is certainly often much more fresh than claims data, but we can supplement it with encounter data. And you know, I would say, you know, in the first meeting with the plans, there was probably a little bit of, you know, some wide-eyed perception of, it looks like, you know, the king has no clothes on here, because now we're sharing. Now, of course, we didn't put the plan names there because we didn't want to have an all-out riot in the room, but we did definitely make it known that, you know, the plans were being compared to each other, and top performers and those that had the most opportunity to improve were being looked at in similar ways at how we should be partnering with them and where their gaps in care are for their patients and how they could do better. So we're coming in for a landing here, I think right on time. The last slide is talking about the takeaways from year 1 and 2. So this is, by this time, kind of a broken record, but ultimately, really, business intelligence is a key factor in success. There's no question that without sophisticated analytics, feedback, and a unified way of managing information, data, and sharing it, we can never mitigate risk successfully. The financial incentives being crystal clear, aligned with outcomes, are absolutely essential. I think if there's one thing that I would look back on now is that when we created our master service agreements, we very early on, because it really was the way we were getting paid, did distribute a lot of funds based upon process redesign and much less on outcome. I think I would have accelerated that now, because there are organizations that are still struggling to achieve the orientation to how outcome is impacting their reimbursement. This idea of real-time data and performance feedback really is a top priority. So looking at something that's 9 or 12 months old in terms of just relying on claims data is not anything that is going to be informative for success. So bringing data in from multiple sources, as you saw in some of the earlier slides, is extremely important. So direct data feeds from partners is really where it's at. Whether those partners are providing clinical service, community-based organizations that are doing home visits for asthma, the health home that is doing care coordination, patient surveys, whatever it is, getting that data in real time and having the platform that can share information with people in a way so that they can really operationalize it and implement is absolutely a top priority. Looking at those missed opportunities that Ashley went through in such nice detail is extremely important, because partners in many respects are still moving slowly out of fee-for-service, and outcome focus on these gaps in care are achievable, but they do need to be brought into individual providers' workflows in a way that does not make it seem like you're doing something extra. It becomes part of their routine management of patients. And often we have not been good in the past about prioritizing that for providers. We did really talk about the focus on high performance, but the Department of Health, with the standard terms of conditions designed with CMS, has identified top priority indicators that pay high performance. And this is extremely important because there is a large amount of dollars associated with this, and we have spent considerable time making sure that those particular indicators are indicators that we can be successful in, because you must know this, and probably should have been stated early on. in a value-based purchasing and outcome-based payment model, you never achieve 100% in every indicator. It's almost impossible. So you do have to understand that there are some indicators where you're going to have gaps, and those gaps need to be made up because from a fiduciary standpoint, you don't want to lose partners because your ACHs aren't able to make financial commitments. Working with the managed care plans, again, is something that I wish both the Department of Health and our PPS had done more crisply earlier on. I think it has paid dividends for us. They're very interested. In particular, some of the plans have been very creative in working with us and have devised interesting strategies for success that I think if we had started out of the gate with, we would be in better shape and the patients would be getting the care that is important. And finally, this issue of social determinants of health is something that while we started out early on and are certainly one of the leads in the PPS here in New York in terms of impacting, these are really important strategies to figure out how funds can be moved into housing, workforce training and retraining, and looking at all of the components that these community-based organizations, local governmental units, social service providers impact, because many Medicaid patients are truly severely hampered by an environment which is not conducive to them having the best of health, whether it's pollution in the air because of refineries, whether it's violence, employment, whatever those individuals, having a spouse, loved ones, or others in prison and then coming out of prison, and how do we get them into public health. These are really very, very important things to work on, and creating a good laboratory for them to have a place at the table to do that is really a top priority. And I think we just hit 12, and that is it.
Thank you, Joe. So we'll move into our Q&A for the last half an hour. Operator, if you could, facilitate some of the Q&A questions being received from our participants. And while we do that, Joe, one of the thoughts that I was having, we've talked a lot about the successes that Staten Island had in sort of executing the strategy. Were there some of those unanticipated issues in the implementation that came along? And I'm sure there were a few. If you could highlight a few and, talk about how you guys went about mitigating those challenges.
Well, I think I kind of covered most of them, although probably not all together. Working with the plans very early on is absolutely a top priority. I think understanding how best to gather data from disparate partners and implementing a community-wide consent is certainly another. I think another component that we probably could have worked on a statewide basis in a better way is trying to identify how, when we're talking about co-located services, either bringing behavioral providers into medical practices, medical providers into behavioral practices, how to do that earlier on and create simplified, facilitated credentialing processes for those organizations with plans are things that were really very important and I think we could have done better at.
Thank you, Joe. Do we have any questions that have come in, operator?
We do have a question that comes from Dawn Bonder. One moment. Dawn, your line's now open.
Thanks. So I'd like to go back to some of the info you shared on the data, especially with respect to timing. When did you start building your analytics machine? And also, I'd be curious if you could talk a little bit about the health information exchange provided either regionally or statewide. And lastly, could you confirm that you are receiving patient-level data from the state?
So, we are receiving patient-level data from the state for all patients who did not opt out of data sharing. We are receiving patient-level detail from our partners, especially those who have implemented community-wide consent models of care in their organizations, which is extremely important. We have also used some fairly creative ways of receiving information from FQHCs that facilitates data transfer very seamlessly, because one thing that I think everybody struggles with is data exchange is great. The work involved in terms of normalizing data, creating an electronic master patient index is very complicated. So these are things that require a lot of time, energy to get in place. But we knew from the beginning, which was a year before the PPS was technically formed, during the planning phase, that this would be a top priority for us. So we were engaged in kind of the beauty pageant of speaking to different information technology partners, evaluating their capabilities, their competencies, checking out credentials. So the day after the PPS was technically formed and the LLC was created, we began putting the data warehouse together, and of course we were recruiting long before that, and put in a very sophisticated data management team here so that we could really do the work that we knew needed to be done. And that was essentially completed, although it's always a work in progress in terms of refinement, even up until this point. I would say by the 6-month mark, we were sharing high-level detailed data with partners very, very early on. And as far as the health exchange, the Rio issue is one that is extremely complicated and continues to be one that we are not completely satisfied we're getting the most benefit that we could. And I think, again, that's a topic outside of an ACH to control. But I think from a statewide level, I don't know how you all interact with the Rios, as we call them here, but bringing them into the fold early on would be something, again, that I omitted, that should have been done very early on by the regulatory agencies, and really all of the ACHs need to work on that. I think I got all your questions.
You did, you did. If I could do one quick follow-up. So is your capacity to get data from your providers to really build out your analytics, is that unique to your PPS, or was that done more broadly across multiple regional partners or greater area than that?
It's very unique to us. I think many people have not, we've supported all of the PPSs in trying to emulate the model to the extent that they have the appetite to do that. Some have replicated much of what we are doing, but it is, of course, somewhat of a unique to a particular PPS, depending upon their geography, partner, scope, breadth. Some organizations may have hundreds of partners. Many of them may not be on electronically shareable platforms and things like that. So there are certainly limitations to the capability. But we have done multiple webinars, as Evelyn knows, for the Department of Health to share the data platform that we created.
Thank you.
It's very high functioning, it's very replicable, and it really is a key to success.
Thank you. That's really helpful.
a reminder, to ask a question, press star followed by the number 1 and record your name. Once again, for those on the phone, to ask a question, press star followed by the number 1 and record your name clearly at the prompt. Our next question.
I know we have some, oh, there we go. I was going to say I'll ask some if we're waiting for others to figure out, but go ahead.
Yes, we do have Jack Davis. Your line is now open.
Thank you. Thank you. I know that, of course, the impetus behind developing the PPS was the DSRIP and the focus on the Medicaid population, but I wonder if the partners in your PPS are working together to focus on patient populations for other payers, for commercial payers or for Medicare.
I would say that that is definitely evolving. That there's a recognition it's definitely evolving. There's a recognition that this platform, especially as it relates to measurement, information sharing, understanding where gaps in care is very suitable to ACO type enterprises.
But it hasn't yet gone into that sort of morphing the PPS into an ACO type function.
I would say that we are probably 3/4 of the way there with a number of different partners to looking at in more concrete ways how it could be done. So it's meaningful conversation.
All right, thank you.
There are no more questions on queue at this time. Once again, to ask a question, press star followed by the number 1.
Okay, while we wait for a couple more questions, Joe, I did have one with respect to the innovation projects that you mentioned at the beginning, setting aside funds in part for innovation projects, which I know are a big deal also for the ACHs in Washington State. And one of the questions that we had was, how did you determine how many funds you would put into regional investments or regional innovation as opposed to some of the other fund flow buckets that you articulated?
So we try to keep aside somewhere between 1% to 3% in a particular project line. But in the projects that focus on infrastructure, we had a little bit more wiggle room there. These are what they call Domain 4 projects. So creating infrastructure improvement is essentially more consistently in line with what project deliverables were. So in those projects, we looked at setting aside somewhere in the 25% over the 5-year total towards innovation.
And what kind of innovations have you invested in on behalf of the rest of the island?
So the first project that we rolled out for innovation was in telemedicine. Readmissions, preventable readmissions and preventable ER use is a 25% reduction goal in over 5 years here in New York. I'm not sure how it will play out in Washington, but as we know, utilization control and cost containment are top priorities, so I imagine they'll be the same or similar in terms of weight there. And we do know nursing home transfers are prevalent. They can happen depending on the organization, with great frequency, and often, speaking from my hospital experience, many times not for the best reasons. And so the first project we did was roll out telemedicine support in the nursing homes, and that has worked dramatically well, and it has actually had a lot of spin-off and benefit to other organizations like those that operate group homes for the developmentally disabled, of which is not an insignificant number on Staten Island, they have gone and they implemented telemedicine that we supported. And what we try to do with these support funds is not support them for 5 years. We usually try to do a 6 or 12-month cycle and then have the group go out and try to secure funding either from a plan, an agency, or a grant. And actually, in both of the cases, we have been successful doing that. So the nursing homes were able to get the plans to pick up and support continued telemedicine. And for the developmental disability, which are residences that are usually staffed, especially after 5 p.m. by aides and mental health workers, there are many transfers that go to the emergency room for conditions really that are not warranting transfer. They're a burden on the patient, they're a burden on the staff, they're a burden on the emergency room, and they were able to win a $1 million grant that was funded by the Dormitory Authority here in New York State. So, you know, in innovation, we've been able to do that. We also introduced education about palliative care on tablets and video system into the nursing homes and hospitals and primary practice offices. That certainly has gone very well, and we get a lot of very positive feedback when it relates to that innovation as well.
All right, thank you. Seeing if that sparked any other questions for those looking for the *1 on the phone.
We do have a question coming from Alicia Serenbacher.
Hi, thank you. So this is Alicia, and I have a question regarding the care coordination components. What did you build in Staten Island, and how does that operate? I know you mentioned you haven't focused as much on social determinants of health early on, but how are you addressing that in the bigger picture?
So from the care coordination aspect, our project is called Health Home at Risk. These are people who do not qualify for a health home, but do require care coordination because of a primary condition that is considered chronic and they're at risk for a second. So we created a platform working with the health home here in our community to engage 6 partners to get referrals from the community at large. People can self-refer, people get referred from the ambulatory setting, from a hospital setting, and they engage patients for up to 120 days and support them when it comes to issues that we spoke about related to social determinants of health. So help with individuals who are in transitional housing, help if they're losing their SNAP or food stamps, help reorienting them in insurance if they have insurance lapses, help with getting individuals who are recently released from prison into public health and insurance and working potentially employable circumstances. So the Health Home at Risk project is one that is very expensive for us, but we didn't feel at the PPS level we wanted to go out and hire dozens of nurses and social workers and then engage in a level of involvement with patients that we did not have experience with, and we felt it was best done by partners, and it helped partners who were doing that already to grow capacity. It allowed them to receive funds at a scale that they weren't receiving them before, hire new staff, get new technology, and you know, it was a more natural way, and ultimately it allowed us not, if you will, to compete with them for doing something that they're doing already.
So thank you. So did you use your design funds to support this? And that's one question. The second question, how do you integrate community, or how did they integrate community health workers into the mix, since it is a workforce that's a growing workforce in this type of work?
It most certainly is. So we did use design and project funds. It's one of our most expensive projects because we recognize the importance of the resource. And from the CHW standpoint, and again, we have done a whole webinars for the Department of Health on workforce transformation. We have partnered with our local colleges here to create scholarshiped community health worker programs. They've run about 14 weeks, and we provide training to individuals who want to be CHWs, so they could be people on a career ladder who are dietary workers, housekeepers, or not even involved in healthcare right now, new college grads. And we have done that, and this is a very successful program, and it's going very, very well. People are hired immediately after the conclusion of the program. And we've also provided project implementation funds. So partners who recognize the importance of hiring CHWs to do this work were given project implementation funds to bring new staff on board and create, get them into the workforce in their organization. So we came at it from multiple ways.
Thank you. That's very helpful. I have one last question, and it kind of pertains to the community health workforce and this workforce development that you've been doing. How did you engage, and how do you continue to engage your community in really authentic community conversations, so you're hearing, as you're doing your interventions, about what the community really needs and wants, and how is that addressed?
Sure. We're very active with the local governmental units, so the borough president has a medical director of community wellness, and we have, what we try to do is not, as I say, compete. We try to facilitate, cooperate, expand capacity. So the borough president is very active in community health and wellness here on Staten Island. He has a medical director and a small team, so we're very active working with them. We're very active working with the public school systems and are involved in school health and nutrition, obesity and asthma. We have health workers that go into the schools, go into homes, and do asthma assessments in the homes. We have education about obesity and activity. We incentivize partners to pediatric practices to work on these things. So we try to do everything in multiple layers, because you can't do one thing. You have to try to do everything. The other thing that we did, which is kind of unique, was use the CDC change tool and have our 3 colleges here, the 3 primary colleges, St. John's, Wagner, and College of Staten Island, take 3 zip codes each and go out with their social work, nursing, and PA students and do real work in the community, do ground-up surveys, meet with community organizations, and try to prioritize what these organizations believe are important in their communities. And we work within the local governmental units to prioritize 1 to 3 projects or initiatives in those particular areas. Because you're absolutely right, if this is where your question was going. When someone believes that they're heard and they own the change, then change is not just contingent upon funding for a project, but will continue over time. So we have been very mindful of being very alert to having focus groups also for individuals with particular conditions to talk, and we incentivize them, pay them to come in and sit with us and spend a couple of hours, do surveys, meet with doctors and nurses, social workers, and talk about things that are going on in their particular areas and try to understand ways that we can refine our strategies.
Great, that's very helpful. Thank you so much.
Sure.
There are no more questions in queue at this time. Again, as a reminder, to ask a question, press star followed by the number 1.
Are there any general questions that weren't covered during this session that were submitted prior?
So I think the only one I can think of is sort of the sustainability model and the role of the PPS beyond the demonstration. So Joe, if you could sort of talk in general about, is the PPS going to be, how the PPS is going to evolve its role beyond the demonstration years?
Sure, and again, I think, part of this is a process that we're going through with partners trying to establish ways that we can be facilitative and collaborative and not competitive. I think as everyone is being moved down the value-based purchasing path, regardless of the payer type or population. We are looking at an ACO possibility, working with the different groups to create an ACO that could accept not just a Medicare risk population, but a Medicaid ACO. We're also looking at supporting IPAs in the community in terms of data management and information exchange and business intelligence. So I think there's a number of ways that we see ourselves evolving, and we do know that we certainly, I think everybody in the country has a challenge around substance abuse, opioid disorder. So we have also looked at ways in which we can evolve certain of our work into drug prevention, and we set up a drug prevention portal, which Staten Island Drug Prevention Portal .org, if you wanted to look at it, that is kind of a real-time public health access for information related to substance abuse. So we think that there's a lot of different ways that the future could evolve, and we're trying to prepare ourselves to be the most flexible when it comes time to see which way the payment cycle may proceed beyond year 5 in terms of government funding. As we know, there was an expansion or an extension of DSRIP in California. Potentially one is being considered for Texas and some other states. So, there are a number of different ways, but those are the primary ones.
Perfect. Thank you.
Sure. I hope this was helpful and informative to the group. Evelyn, thank you, and Vidhu for organizing this. It was my pleasure to do it, and if there's anything I can answer when people reflect on the slides or questions that come up afterwards, I'm happy to work through you to help them.
Thank you so much, Joe, for your time. For those on the phone, this has been recorded, so you will be able to listen it back, and please work with us if there are any other concepts you want clarified. We'll figure out how to get you the answers to those as well. And Joe, thank you again, and Alice, thank you so much for your time today. Or sorry, Ashley, and all the best on the next steps in your district endeavors.
Thanks very much. Bye, everybody.
That concludes today's conference. Thank you for your participation. You may now disconnect. Speakers, please stay for your post-conference.